The title is Medical Alerts in Your Shopping Basket. Let's see if I can just do the arrows. No, how does this work? Just here we go. Yeah. All right. So I'm going to start off with a bit of background on ovarian cancer. So if you don't know already, then this slide will probably tell the story. Ovarian cancer is a terrible disease to get. The vast majority of patients, about 75% of ovarian cancer patients, are diagnosed at stage 3 or stage 4. And you can see from this survival graph here, stage 3 and stage 4 have the worst survival. Stage 4, 5-year survival is about 5% of patients would reach 5 years. So it's very poor. Why is that? So why are they largely diagnosed late? One of the main reasons is the symptoms for ovarian cancer are quite vague. You know, if I was just to ask the women in this audience, do you know the symptoms of ovarian cancer? Even those that work in healthcare fields don't know them. And we've got some shaking heads over here. So that, you know, that tells the story that, you know, weeing more often, stomach pain, bloating, struggling to eat. These are symptoms that you wouldn't necessarily think, oh, that must be ovarian cancer. And the same is true when those patients go to their GP with these symptoms. Even the GPs have trouble diagnosing ovarian cancer. They'll think it's something else. They'll think it's IBS or any number of more common things. Ovarian cancer only happens in about 2% of women, so it's quite rare. So one of the other things that kind of led to this study was anecdotal evidence, talking to ovarian cancer patients, talking to clinicians about the sort of products that patients buy to treat their symptoms. And the story was about pain medication and Gaviscon. So Gaviscon is often used for that bloating or that indigestion feeling that the patients have. We also talked to ovarian cancer patients, and this is one of our patient advocates, Fiona, who has been involved in the study since 2017, since its inception. And this is her story. So she was diagnosed with ovarian cancer on her 25th birthday. And as you can probably imagine, at that age, it would come as a complete shock. She'd been through many, many GP visits before they finally, probably about 2 years of symptoms and GP visits before they finally diagnosed her with ovarian cancer. One of the symptoms she talked about was acid reflux. So she couldn't leave her house without antacids in her bag. And this is something she told us. She had Gaviscon in her bag every day for about 18 months because she couldn't leave the house without it. She even tried things like gluten-free diets and various things, changing various aspects of her diet, and nothing seemed to help until she said she had her surgery, and then the symptoms resolved, and you know, obviously the chemo and various things followed. So yeah, so that's she's quite young for an ovarian cancer patient, but the story itself is actually quite common for ovarian cancer patients. So this kind of led us to this study. This is the Cancer Loyalty Card study. It started as a pilot study that was funded through a sandpit event. So CRUK had invited us to a sandpit to come up with this idea of the big challenge was using big data for earlier diagnosis of cancer. And we came up with the idea of using shopping data as our big data source to try and use that to help ovarian cancer patients get to their diagnosis sooner. And this was the hypothesis. What if we can identify a change in purchase behavior that might indicate self-medicating of your symptoms before you would otherwise go to the GP? That's what we were really looking to try and find out. And just wanted to talk a little bit about the patient journey, really. This is I guess the journey for an ovarian cancer patient. It starts off with the patient interval. This is the period of time from when you first notice symptoms or changes in your body to the point where you think, actually, this is alarming enough for me to go to the GP. So that's that patient interval. And we want to try and with our study, we're trying to reduce that. I'll come back to that in a moment. We've then got the GP interval. And as you've heard, and as you probably know, patients will go through multiple GP visits up until a point where the GP sends them to secondary care for their cancer diagnosis. This, you know, for ovarian cancer, it'd be ultrasound and CA-125 screening tests. That then leads you to your diagnostic interval. So from that time point up until the time you've been diagnosed and your treatment starts, this is then what's on this slide, post-referral interval. And that post-referral interval actually has some NHS or NICE guidelines saying that cancer patients should be treated within 62 days of their diagnosis. And there is actually a threshold where they say we must meet that deadline for at least 85% of our patients. Can you have a guess what percentage of patients actually meet that these days? It's not 85%, is it? No, it's actually down around about 60%. So 60% of patients are currently meeting that deadline, which is really not very good. So, you know, that we know keeping that timeline short improves outcome. And we're not meeting that. And so that's something the NHS really needs to get to grips with. But if we come back to the earlier interval, the pre-referral interval, you can see the range there from anywhere from 14 to 150 days. So some patients are going, you know, almost a year sometimes through these referrals, through GPs, not knowing what to do up until they get their diagnosis. And the whole aim of CLOCS is to look at that patient interval and just shrink that right down. Can we reduce that by a month, 2 months, maybe even 6 months, and get that patient to the GP sooner? That's the main goal for what we're trying to do. So this is just the outline of the talk. I'm going to talk a little bit about acceptability of data sharing, because this study is all about sharing data. I'll then show you some of the data from the early detection of ovarian cancer study. And then I'll talk a little bit about future work, what we're doing with CLOCS 2, because that's been funded now. And then if I have time, I'll come to this study looking at risk factors for ovarian cancer. Obviously, when we're working with Boots and Tesco's, we've got, for instance, with Tesco's, we've got a lot of information on diet and various other things that people are buying that might influence their risk of cancer. So I can talk a little bit about that. Right, so let's start off with the acceptability survey. So we put out a survey, it was in July of 2020. About 1,500 people responded to this survey, and there were lots of different questions we were asking. But one of the main questions we were asking was, how willing are you to share your shopping data for health research? That's the main thing we wanted to know. We were also asking, who would you like to share the data with, and how would you like to receive invites to studies and various other important bits of information. So what did we find with that? First thing we noticed was when we were asking, who are you willing to share your data with, people were willing to share their data with the government. And I think embedded in that is the NHS. People are willing to share their data with the NHS. People are willing to trust universities with their data, academic institutes. When it comes to private companies, people are a lot less willing to share their data. And that kind of comes back to when we're asking people to participate in this study, and we've had this discussion quite a lot. Who should we get the invite? Who should the individuals get the invite for the study from? Is it better if it comes from us, the academics? Is it better if it comes from the GPs? Is it better if it comes from Tesco's? Actually, could Tesco's just email all of their cardholders and say, would you like to participate in this study? From this data, it kind of suggests that if Tesco's was to send that email out, it probably wouldn't work very well. People would be less willing to share their data if Tesco's was asking for it. And we actually ran a little pilot study with Boots, actually. We got Boots to send an email out to 1,000 participants to see if they could join CLOCS 1, the first CLOCS study. We got 5 people back. So very, very few people were willing to join the study, having received that email from Boots. So we kind of learned a lesson there. That was quite important. But what kind of data are people willing to share? We asked them about loyalty card data, about shopping. 52% of people were willing to share that type of data. We asked about internet search history, smartphone data, wearable devices, social media data. And you can see in this graph, about 30% of people are willing to share those types of data, which kind of tells you also a little bit about how people think about these types of data. Obviously, I was at a meeting with Google Health last week, week before, and they're very interested in Google search terms and using that for health research. There was a study from a colleague at Imperial that showed using Google search terms, you can help diagnose ovarian cancer potentially sooner using what people are searching online. But there's a lot of technical challenges with that kind of work at the moment. But one of the challenges was people weren't willing to participate. They lost a lot. If you look at the consort diagram in that study, they lose a lot of people from not willing to share it. Smartphone data, wearable devices, you'll find more and more studies using wearable devices these days, and I think that will become normalized. People will be more willing to share them. I've got a Fitbit that I got because I participated in a study. It's actually a nice way to pick them up. Free. So I think people will be more and more willing to share that kind of data soon. One of the predictors of whether you're willing to share shopping data was age. It's very clear. And I think you probably see this in anything that relates to data or anything digital. The older the participants were, the less willing they were to share the data. And we've been doing some work with various groups to try and unpick that and to try and understand what can we do to help people trust us more or be more willing to share data and understand why this is the case. Because we want to turn that around. Because if you think about it, if we want to do more studies, and we are doing more studies, and they're going to be bigger studies, we want a larger percentage than 50% to be able to say yes to the study. We want to sort of push that up however we can. All right, so let's move on to the actual data from this study. So in the end, we recruited 153 ovarian cancer patients, and we recruited 120 controls, but we used matching, sort of 2-to-1 matching for cases and controls, so we could actually analyze the data. It was one of the problems in our first study. We recruited 450 or so controls, but because at the time we had to ask for ID verification documents for control participants to participate, we lost a lot of people. They didn't want to share their documents. So we ended up only 120. But just to explain how these graphs work, we've got our diagnosis date. So all of the data is aligned at the cancer patient's diagnosis date, and the matched controls are aligned to that date. And we've got 2 years, going back 2 years of data for these individuals. And this is looking at cumulative pain and indigestion medication. So this was the hypothesis going in, that these were the 2 products that we were interested in. And you can see the first one, that's the cumulative graph. The red line is the average, the cumulative pain in cancer patients compared to controls in the black line. But this here is just a Fisher's exact test, looking at each month going back from diagnosis. So if we just see this data here, going back up to 8 months before diagnosis, these purchases, cancer patients are starting to buy about 3 times as much Gaviscon and pain medication compared to the controls. And it's significant all the way through up until the diagnosis. We also used another test where this is now area under the curve that we're looking at on these graphs. And we asked the question, well, okay, if indigestion was driving this association, and that's the main product we're interested in, let's just focus on all the people that bought indigestion medication. Then ask, how much indigestion medication are you buying at what point? And is that predictive of a future ovarian cancer diagnosis? And when we do that, we can see that the area under the curve is significant. It goes, so the area under the curve is about 0.68, I think, 0.65, going back up to 12 months, 13 months before diagnosis. So that kind of tells you that if you're buying indigestion medication, you're going to start buying more of it and keep buying more of it for 12 months leading up to your diagnosis. So that, and of course, you have to bear in mind the numbers are getting smaller here. We've got cases, 63 cases here are buying indigestion medication, 112 controls were buying it. If we stratify now on early versus late stage, so remember I told you late stage diagnosis is the most common in ovarian cancer, and you can see that it bears out in our numbers. Stage 3 and stage 4, we've got 50 patients. Stage 1 and 2, we've only got 12 patients. So the numbers are, again, very small, but you can see where that association is coming from. It's coming from the late stage patients. So this is in blue. These are the stage 3 and 4 patients who are buying that product, treating their symptoms for 13 months before their diagnosis. And there's this one weird little spike in the lower stage patients. I kind of know what that is. It kind of aligns, it's about 3.5 to 4 months before their diagnosis. And that kind of aligns with the time that they first go to their GP. And when they go to the GP, it's very likely the GPs are telling them go and buy some Gaviscon. And I think that's what we're seeing here. I'll show you that in a moment on the next slide. So this is the summary of the early diagnosis analysis. So we also had a survey where we asked lots of different questions. One of the questions was, when did you first go to the GP before your diagnosis? On average, that was about 3.5 months before their diagnosis. We asked them when you first recall having symptoms, and on average, that's about 4.5 months before their diagnosis. So around about a month before they go to the GP. So we're showing that over-the-counter medications are increasing approximately 8 to 9 months before their diagnosis, possibly longer, possibly up to 12 months. And we're obviously interested in that period now between when they first go to the GP and when they first start buying these products. Because if that's maybe 6 months, there's a possibility we could use this data if you imagine us monitoring these individuals and following them up and saying, all right, your behaviour has changed, you've triggered an alert, we'll send you an invite to the GP, get you to the GP sooner. Because if we do that, we'll probably make a difference on their outcome. A couple of other things to note on here. This is their first GP visit, but obviously there's multiple GP visits for many of the patients before they actually get their diagnosis. And the other thing to note is there were actually 45 patients that had no GP visits at all, actually. And these are the ovarian cancer patients that are typically diagnosed at A&E. So they've presented to A&E with really severe symptoms, more than likely stage 4, and more than likely those patients are probably not going to get surgery or chemo because they're too unwell. And their outcome is really poor. So imagine that patient, let's pick them up 6 months earlier. So instead of here at A&E, let's pick them up 8 months earlier. Then they're going to get surgery and chemotherapy because they're going to be well enough to get it. And you're going to make a massive difference to their outcome. So those are the sort of patients that we really want to try and catch early. And as I said, with the acceptability, 52% are willing to share their data at the time we did this study. And, you know, as I said, we want to try and increase that number somehow. So we've been coming up with ways to try and talk to people. We've been doing a lot of sort of community events to try and talk more about that. Now, obviously, when this paper came out, we got quite a lot of media attention. It's the sort of study that the general public can really latch on to because it's really relatable. Everybody who's got a loyalty card knows what that card is doing, collecting all of their data. So everybody was really interested in it. And there's a lot of comments online. I always love looking at particularly the Daily Mail, my favourites. This guy is saying it's a bit of a corker when you have to get diagnosed by your loyalty card if you can't see a GP. I think that kind of comment is, you know, we also had people on there saying, that's it, I'm cutting up my card. I don't want Big Brother to watch me and things like that. There's a lot of distrust of the companies and the way they use this data. We're also involved in a documentary for Channel 5 where the journalist Alexis Conran was asking this question, are loyalty cards worth it? And it was interesting because we participated in this study. The producers of that documentary brought Alexis to my lab to talk to me about this study. He had no idea why he was there. So he came in a complete skeptic. And by the end of talking to him, I kind of changed his mind, but not really. And it was interesting, this particular, you can look it up online. They've changed the name of this documentary now. Either they didn't get enough traction or they wanted to jazz it up. It's now called Loyalty Cards, the Big Rip-Off or something like that. Mm-hmm. But you can find it on Channel 5. And this was a Canadian TV show that were interested in this. So the other thing that we've been doing is a lot of community engagement. So we go out to cafes, talk to cancer patients, and we've participated in something called Imperial Lates, which is an event that they have where they bring the public in to talk to scientists about their work. There's about 2,000 people come to that event. And actually it was for this event where we trialed we've developed a game called Cards Against Research Data Security. I don't know if you know the game Cards Against Humanity. It's the same thing, only it's less rude. But the idea was to try and gamify it and try and make it fun for people to learn about data security and data privacy. So we trialed it at Imperial Lates, and then we actually used it at the Great Exhibition Road Festival. This was in early June, where we had a stand, and there's something like, was it 40, 50,000 people come along to this event. And we had, I don't know how many couple of hundred people pass by our event, and we were playing this game with them, but we were also conducting a research study where we would ask them before they play the game, would you be willing to share your data? Here's a ticket, put it in yes, no, maybe. And then they play the game, and then they have another ticket, yes, no, maybe. And we're asking the question, does the game change people's minds? And it turns out it does. So it does actually increase people's willingness to share. So we're actually going to try and publish that soon. So it's an interesting way to talk to the public with a game. I think it worked quite well. The other thing that we've been doing, one of the things that we've recognised in our first study was the population was overwhelmingly white. 95% white population. Now, that's not surprising. Our best recruiters were in Brighton and Swansea. It's very white communities. We did have a recruiting centre at Hammersmith Hospital where their ovarian cancer patients are more than 55% non-white, but they only recruited 6 patients for us. They didn't do very good. But we've been out talking to communities. We've got a workshop planned with the Bangladeshi community. We've got something planned with the Somali community in Harrow. And the things that we're talking about are what would make you or help you be more willing to participate in research? Because we know they're not participating. How can we make them or convince them that it's worthwhile? Is the research relevant for you? You know, if we did this research, do you imagine yourself benefiting from that? So we're asking those sort of questions. And what are the barriers to online digital participation in studies? We're going to try and assess that with these workshops. I mentioned age earlier. I did a workshop with the Age UK group where we had it was an online Zoom meeting. So it was kind of a biased selection, 70 plus. There was a few 90 plus women there. But these were women who were willing to get on a Zoom call. So digital participation wasn't a barrier for them. But we did talk about why it might be for others. And we worked out some of the things that might help with age community. There's other groups that we've been talking to as well about this work. All right, so let's move on to what we're doing in the future. So CRUK have funded this work again, and the new study is going to be mainly looking at these 4 cancers. Ovarian cancer, we want to validate what we did before. We're going to look at colorectal cancer. We're going to look at esophageal cancer, and we want to look at pancreatic cancer. So there are particular products that we're already hypothesizing we will find for some of these cancers. Pancreatic cancer is one where we're not quite sure. I know coughing and various other medications might be related, but we also know that pancreatic cancer is the worst cancer to get. So if there's anything we can find that'll help, it's going to be worthwhile. We're going to be looking at controls, and there's 6 other cancer types. I'll show you those in the next slide. We're going to do, I guess, smaller pilot studies for those cancer types. So we're going to be doing case control studies again, same as we did before. And we've also got behavioural science. One of the things that we did with the first study and this one is we've embedded the data science and the behavioural science together. And they really sort of bounce off each other quite well. Some of the things we're trying to understand is the psychosocial factors that facilitate self-care behaviours. So what is it about you that makes you go to the pharmacy to buy that product or not? And then to co-design and assess the feasibility of an intervention. Because one of the most frequently asked questions that we get is, you know, how do you let people know? What kind of alert is this? So who's going to participate in this study? We've got our cases. This lists some of the other cancer types that we're interested in, and we've kind of picked them for various reasons. The controls, obviously, people that haven't had a diagnosis of cancer in the last 6 years. I should explain that 6 years, actually, because when we recruit a participant today, Tesco's has 6 years of data stored. Beyond that, they start deleting it. Which is a bit of a shame, but that's their data policy, that's their privacy policy. For Boots, it's actually only 4 years. So we only have 4 years of data from Boots. And we are recruiting through various mechanisms. So remember I told you about the trust with where that message comes from. So we're going to be sending a text message from GP clinics. We've got a network of academic or clinicians, GPs, that are going to identify participants and send them a text message. We've also started working with something called Be Part of Research. You may or may not have heard of it. This is a new platform by NIHR where they've got something like 600,000 or 700,000 people signed up as members of Be Part of Research. And when studies go live for recruitment, they email anyone who's eligible and see if they can sign up through that route. So these are people who are already predisposed to participate in research. So we think we're going to probably do fairly well with them. And there's a third option, which is you might hear about the study from someone in your household that got recruited. Now, one of the important things in this study is we need the primary card holder. So whoever's name is on that Tesco's card or the Boots card has to participate in the study. Otherwise, we can't request that data. So if somebody else in the household gets invited, they need to invite the primary card holder as well. So they'll both be part of it. And I guess this highlights one of the other frequently asked questions is, what if you're buying for somebody else? Everybody, will be buying at Tesco's for everyone in their household. And so we have always argued that the difference between the cases and controls are also buying for everyone in their household, as are the cases. And so those won't be differences between cases and controls. The differences will be the things you're buying for that cancer case. So that's why the good matching is kind of important, so we can understand what the actual differences are that we see between those two households. So we are looking at household level data, but the individuals participating do have their differences that we can sort of pick apart. The other frequently asked question is, what if they don't consume it? So, I use bananas as an example. How often do you buy bananas and let them just rot on your bench and then you throw them out? So just because you buy it doesn't mean you consume it. And it's the same with medications. You might buy a large pack of Gaviscon and sit it on the shelf at home for the off chance that you might need it. But what we've found is those that need it, those that are using it often, are buying it often. They're not buying it sporadically. And it's that change of behaviour that we're looking for. So these are the sort of things that we often hear about. All right, so we sort of come to this point here where we've got something, we've got a signal that we can detect. We know that it probably relates to ovarian cancer, that we know what sort of predictive rate is. We can probably add information. We've got, I guess, machine learning algorithms that can put more data together to make that algorithm better. So with the data that we've got at the moment, the area under the curve gets to about 0.7. We could probably get it as high as 0.75 by adding a couple of other things into that data. But what are we going to do with it? How can we then monitor people prospectively and then intervene, do something about it? So these are the various options that we could discuss. One is a text message alert. So one thing to say, any program where we're monitoring data, you must opt into it. You need to consent to this because people are worried about Big Brother watching them. So we've got to make sure you consent for us to watch your data. So maintaining trust and data security is paramount for this. What about the NHS app or maybe another app? We could perhaps integrate something with an app that then just sends you a message, text alert or something, or maybe even alerts your GP and then possibly even directly just booking an appointment for you. That might actually help people get to the GP sooner if they know they've got an appointment. It might be a detailed letter. Obviously, you need to give people information. One of the other things, you might be buying that product for another reason. It might be for someone else in the household or something like that. So you need to give them, you might need to give them a letter detailing why they've been alerted, what's the product, what are the potential symptoms, what should you go and talk to the GP about, just to give people more information so they're more armed with the information. Or if the test is really good and can actually diagnose cancer patients really well, we might just send them straight to the rapid diagnostic clinic and just bypass the GP altogether. But that would only really work if the false positives were really low, because we don't want to waste their time either. So those are the sort of ideas that we're going to be discussing, and we're going to be planning these sort of co-design workshops where we're bringing GPs, patients, cardholders, stakeholders like Tesco and Boots and various other people all together in the same workshop to actually talk about this and just work out what's going to be most feasible, what's going to work the best for everybody. And then we're going to plan a feasibility study and try and run that through this CLOCS study. Right, so I think I've still got time. Yep. So I just want to talk about risk factors. So with this data, as I said, with Tesco data in particular, we can go back 6 years. And through our data so far, we've kind of seen that the symptomatic period where the products they might be buying might relate to their symptoms is about 12 months, maybe going back as far as 24 months. And so when it comes to risk factors, we've been focusing on the period before that. So we can look at perhaps years 2 to 4 before their diagnosis and try and understand what's going on in that period that might influence their risk. And I'll show you one thing that we've found that I thought was quite interesting. A few years ago now, there was this paper that showed antihistamine use was associated with the risk of ovarian cancer. In fact, it was actually protective. So if you're buying antihistamines, your risk, so in this particular paper, over the whole cohort, it wasn't significant. The odds ratio was about 0.75. In the population that was under 50, it was significant. The odds ratio was 0.72. So if you're buying antihistamines, you're potentially protected against ovarian cancer, which I thought was quite interesting. And because this paper came out and we had the data already for CLOCS, we thought we may as well look at it and see what we find. Another thing related to this is there is an association between allergens and IgE and cancer risk and survival. So this is a group at King's College that showed that IgE sensitization might be protective for gynecological cancers. They were looking at endometrial and ovarian cancer, I believe. And again, it was quite protective, significant. And actually, it's led them on to now develop an IgE-based therapy. So there's an antibody called MOV18, and they've tested it in this phase 1 trial. Now, I know, don't read too much into phase 1 trials, but when you read things like with evidence of anti-tumor activity observed in a single patient with ovarian cancer, you kind of get excited. You think, oh, actually, it might actually work. It kind of adds to this whole story that this IgE might actually be important to protect against ovarian cancer. So this is what we found in CLOCS. So the black line here is the controls. The red line is the cases. And we're looking at the sum of all antihistamine products. So there were two main antihistamines, cetirizine and the other one I can't remember. They were the two main products that people were buying. And we analysed it every 3 months, basically, for the seasons. And we were focusing on this period that goes back to 2016. So remember that the diagnosis of cases was around about 2021 up to very early 2022. That's when most of the cancers were diagnosed. And one of the first things you see here is that the purchase for antihistamines is seasonal. It's probably not surprising. A lot of people buy it because they've got seasonal allergies. So when I saw that, I thought, oh, that's actually quite interesting. I wonder what it means. But when we actually looked at the numbers, so overall, across, if you look at all antihistamine purchases, it's not significant in this data set. The odds ratio is 0.68. But when we look at for those that only buy it in spring or those that only buy it in summer, significant in this data set. Autumn and winter, not significant. Now, I should point out that we've tried to publish this. We've sent it to a couple of journals. Nobody wants to publish it. The numbers are too small. They've just said, no, it's too small. We've sort of dumped it on medRxiv. So it's a manuscript on medRxiv, which you can go and read if you want. The reference is just there. But what we kind of realized is one of the reviewers said you need to look at either those that buy it seasonally only versus people who buy it all year round versus those that never buy it. And that's the analysis we did here. And actually, it turns out it's quite a clever way to look at it, because it shows quite clearly that those that are buying it year round, so these are people that have probably got a cat allergy or something that they need antihistamines year round for, versus those that have seasonal sort of hay fever or allergies just only in spring and summer, it's quite significant. Now, even though the numbers are small, I look at that and think, actually, that makes me think. That's really interesting. So, we're kind of holding on to this for now. We're going to wait till the CLOCS2 data comes in, all the ovarian cancer patients, and try and replicate it, add to the numbers, and then we'll sort of revisit this story. But it's still, I'm still quite interested in it. So I'm not an immunologist, but it clearly to me shows that it's not antihistamine itself as a drug, it's the allergies themselves. And so it makes me think, well, what about allergies? What do we know already? And actually, we already do know quite a lot. This is a review that was a few years ago now that shows that allergies are actually, it's quite a mixed bag, actually. So for bladder cancer, prostate cancer, allergies increase your risk. For glioma and pancreatic cancer, decreases your risk if you've got allergies. If you've got breast cancer, lung cancer, doesn't really associate with risk, although there's an interesting difference between males and females. There might be some sort of biology behind that that might explain a difference. And for ovarian cancer, in this study, they said it was equivocal. So the odds ratio is 0.75. It's not significant. So this, again, having done all of that reading, I kind of started thinking about this. Well, so why? Why do some cancers increase risk, some cancers decrease risk? That's quite a very strong differences too, actually. So what is it about those cancers versus these cancers that explains that biology? Quite interested in that question. And what part of this allergic reaction is actually preventing ovarian cancer? So the first idea, these are various ideas, and there's probably several others as well, that this intermittent seasonal IgE activation that you're getting, that hay fever reaction, is actually like a regular burst of immunotherapy. You're getting, if IgE can kill off cancer cells, if you're hyperactivating that once a year, you're possibly clearing out cancer cells while you're doing it. And then obviously take the antihistamines to suppress that. It might be that cancer cells just look like pollen, the cell surface markers or something. The immune system's already got a pre-existing memory for that structure. And so it can perhaps just find cancer cells. Now that one's probably a bit more out there as an idea. But, there are other ideas like that you could probably imagine it might have something to do with histamines, actually, because we know histamines are very important for cancer cell growth. So yes, there's lots of ideas here, and I'm quite interested in exploring this further. But we put the brakes on this until we get more data and support it, I think. But I'm more than happy to talk about it because I think it's a really interesting idea. All right. So with that, I'm going to finish and just thank various people. Obviously, there was a whole host of people involved in the first CLOCS study, but this is my current lab, and the people involved in CLOCS2 are Safsa, Seema, and Yuska. We've also got Kevin, who's the PhD student who is doing the AI algorithms, and we've got a couple of master students on here as well, who are both looking at various aspects of this data. And these are all the funders. So obviously, CRUK is the biggest one because they've funded all of the CLOCS work so far. But I'm going to end, and we'll see if there's any questions.